So now that we have an idea of the pathophysiology surrounding asthma, I'd like to talk about a few of the signs and symptoms that we see associated with this disease process. So if you remember, in the asthmatic patient, they have chronic airway remodeling, which then can lead to some fairly significant acute airway remodeling in an asthma attack. So we have our normal alveol or normal bronchiole here. If we take a look at our bronchioles in an asthma attack and during just regular day-to-day life with asthma, we can see a couple of differences. So when we're looking up here, this is the patient with asthma. This is our basically chronic airway remodeling. So what we're seeing in this instance is we have obviously that smooth muscle, the hypertrophy of the bronchial smooth muscles. So we see an increase in bronchial smooth muscle size. And because of the increased size or swelling of the basement membrane and the swelling and edema that's occurring normally, we have a decrease in lumen size. And in terms of signs and symptoms, this is going to lead to a couple of things. So often when we are looking at the asthmatic patient, we see things like exercise intolerance. So when the person attempts to exercise, they have an inability to do so because it exacerbates their signs and symptoms too greatly. So one of the things that we do see with asthma is exercise intolerance, tolerance or intolerance of cold or hot environment. So we can see asthma being exacerbated by cold or hot temperatures. And again, this is because of the irritation of the airway. So when we're looking at signs and symptoms, one of the things that we can see again is this exercise intolerance, or the person can have an intolerance of cold or hot environments, and this can lead to triggering of their asthma. So if we look at the other airway down here, this is what we're seeing in an acute asthma attack, or this bronchiole is the remodeling that's going to occur during an acute asthma attack. So one of the things that we're going to see is the bronchoconstriction. So we know that we see bronchoconstriction of the airway. We still have the increased size of the bronchial smooth muscle, and we're still going to have the narrowing of the airway due to the swelling and edema that occurs in the airway. So we still have this decrease in lumen size due to the swelling and edema that is occurring. Decrease in lumen size that's a result of this swelling and edema that's occurring in the airway. Now what's interesting about the acute phase is we're also going to have some mucus production. So we also have this mucus production, or this buildup of mucus in the airway, which is going to decrease our lumen size as well. So in the acute phase of this asthma attack, we have bronchoconstriction, we have a greater decrease in lumen size because of the bronchoconstriction as well as the mucus production, and then swelling edema is getting worse. So basically our lumen size is decreasing even further because we have the swelling and edema of the airway. It's going to lead to a number of kind of characteristic signs of asthma. And one of the things that we often see in this patient is wheezing. So wheezing basically is occurring as the person is trying to move air through the narrowed airways. So as we see with asthma, with our bronchiole, it's become much smaller. We're seeing a decrease in size of the bronchioles. So as air is trying to move out of our bronchial tissue, it becomes much more turbulent and starts creating that characteristic wheeze that we see. So we see an increase in turbulence. So we see an increase in turbulence of airflow, which is going to cause this wheezing that we see. Now, this wheezing is generally going to be increased on expiration. And the reason for that is because when we have expiration, our intrathoracic pressure tends to increase and our airways become narrower. So if we're looking as this person tries to expire, what's going to happen is we're going to have an increase in pressure, or an increase in intrathoracic pressure on these bronchioles, which can cause to a further narrowing of the airway. So as a result, when the person expires, the bronchioles become much smaller, turbulence increases, and we start to see this wheezing. So again, the wheezing is generally going to be increased on expiration or it's normally going to start on expiration. So as someone's entering an asthma attack, we see the wheezing occurring on expiration, and as the edema and the mucus production and the bronchoconstriction gets worse, this can eventually lead to wheezing on inspiration, which is a fairly ominous sign and indicates progression of the disease. So wheezing is one of the characteristic signs that we're going to see in asthma. Another thing that we'll see is prolonged expiration. So we'll see a prolonged expiratory phase, and this is because of the same mechanism that we've spoken about here. So as the person is trying to breathe out, or if we kind of show we'll draw their alveoli here. So in terms of prolonged expiration, what's happening is as the person is trying to expire the air, or they're trying to get air out of the alveoli, we know that because of the increase in intrathoracic pressure, we're going to see an increase in, or a decrease in diameter of our bronchial lumen. So on expiration, we know that because intrathoracic pressure is increasing, this lumen is going to decrease in size. So the bronchial lumen is now decreased in size. And you have to remember that we already have swelling and edema and all those things that we've talked about previously that are going to be hindering expiration to begin with. So we have now this decrease in lumen size. And we've talked about the fact that we have mucus filling this airway as well. So we have lots of mucus filling the airway and decreasing or further narrowing our lumen size. So the problem is on expiration, as this air becomes, or we try to forcefully expire, what can happen is the mucus can make its way up to the alveoli, or to the bronchiole, which is already narrowed, especially during expiration, and it can start blocking exit of air. So it's much harder to force air out through the airway because of the narrowing and the mucus that's plugging the airway. So as a result, the person expires longer, so we end up seeing them expire for a longer period of time to ensure that the air is moving out under lower pressure and can make its way out of the airway. So we see prolonged expiration, and again, normal expiratory phase is usually about 1 to 2 or 1 second inspiration, 2 seconds of expiration. In this case, you can start to see 1 to 3 or 1 to 4, and again, that's an attempt to avoid alveolar hyperinflation, or the patients are trying to decrease alveolar hyperinflation by increasing the expiratory phase. So we can see prolonged expiration as well. Obviously, with an asthma attack, we're going to see an increase in work of breathing. So as the person enters respiratory stress, they're going to start doing things like using their accessory muscles. So we see an increase in work of breathing. And again, that's going to be presented by accessory muscle use, so using those sternocleidomastoids or intercostal muscles to breathe. So we see accessory muscle use. We're also going to see things like tripoding, or the patient's going to put them in a position where they can use those muscles with the greatest force and not have as much resistance. So we can see increased work of breathing in these patients as well. The other problem with this air trapping is you can start to see barrel chesting. So as these alveoli do become hyperinflated, or if this process of prolonged expiration is not working, so again we have the edema in the bronchiole, as well as that increased pressure during expiration, which can lead to that air trapping. The problem is that the alveoli become hyperinflated, or we start to see an increase in air within that alveoli because air is able to make its way in during inspiration. So we have air making its way in and filling our alveoli, but during expiration, again, we have that mucus, we have the increase in pressure on the bronchioles because of expiration. And as a result, the air cannot make its way out on expiration. So on inspiration, we have air making its way in, and then on expiration, we do not have air making its way out. So that can present as a barrel chest, or the patient, the lungs may appear hyperinflated, or the anterior posterior diameter, or the amount of basically space between the front and back of their body increases, or their chest looks puffed out. Now, one of the problems with this is air continues to fill the alveoli. This can lead to rupture, or can lead to a pneumothorax. So we can see the lung can now rupture as it hyperinflates, and air can fill the thoracic space. So this patient is at risk of a pneumothorax as a result of asthma as well. So along with this increased work of breathing, one of the things that we might see is a barrel chest or signs of hyperinflation. So barrel chest or hyperinflation. Now, as the patient ends up getting worse, some of the things that we can see are this pneumothorax that we talked about. So if we see rupture of the alveoli, this barrel chest can lead to rupture and subsequently pneumothorax. As well, as the patient gets much worse and we start seeing them enter the status asthmaticus, or an asthma attack that's much longer than a normal asthma attack and doesn't respond to normal treatment, what can happen is this bronchiole can become completely filled with mucus. We have too much narrowing and we can no longer get air into the alveoli. So if no air can move terminally to this bronchiole and no air is moving through our bronchiole, what we can end up seeing is silent chest. So in the later stages of asthma attack, or in acute asthma attack, we can start to see silent chest. And this is the result of no air entry. So silent chest usually starts in the bases and can move its way up, so the person stops being able to get air deeply into their lungs, and as a result, we stop hearing any noises or stop hearing any airway sounds as we auscultate. And again, this is a very ominous sign and usually is preceding death of the patient. So we can have silent chest. We can also see a decrease in LOA, so the patient's level of awareness can start decreasing. And again, this is what we talked about before. So as this alveoli is no longer able to have oxygenation, so if we're looking at our alveoli over here, and we know that we're generally looking to have oxygen going in, which is generally not going to happen in this case. This person will have a VQ of less than 1, or they're going to have some sort of ventilation problem. So oxygen is not making its way in, and as a result, we cannot have exchange of CO2. So all of the CO2 that's making its way to the alveoli is simply being shunted from left to right, and we're not seeing any reoxygenation. So the person becomes hypercapnic, which can lead to a respiratory acidosis and can decrease our level of awareness. We see hypercapnia, which leads to respiratory acidosis. And eventually is going to lead to CNS depression, as we have that cerebral edema and the dysfunction of our neurons as a result of this acidosis. So we can see wheezing, prolonged expiration, an increase in work of breathing, barrel chesting, a silent chest, a decrease in LOA. Obviously, we're going to be looking for the other signs and symptoms that we have with this, so things like a decreasing oxygen saturation, because the person is no longer oxygenating well, so we see a decrease in oxygenation, or an SpO2 is going to decrease. As the person initially responds, so if we're looking at changes in end-tidal CO2, we're going to see kind of two things happening. As the person initially responds, or we see this increase in respiratory rate and we see compensation, we're going to have a decreasing end-tidal CO2. Or the patient's going to be blowing off an extensive amount of CO2. The problem is that as that person starts to fail, so as our respiratory rate decreases or the patient becomes fatigued, the problem is that we're no longer going to be able to compensate, and we're going to have an increasing CO2. So a high end-tidal CO2 in asthma is generally a sign of failure, or it's generally a sign that the patient is entering into failure. So these are kind of the core signs and symptoms that we can see with this patient. The other thing I wanted to mention with asthma and prolonged exacerbations of asthma is how we can end up in cardiac arrest. So I think one of the big problems that we've shown here is this the respiratory acidosis. So the person, as they are no longer oxygenating and they are no longer sending or exchanging CO2 for O2, we get a respiratory acidosis, which can lead to CNS depression and death. Now, another large issue that we see occurring with with asthma is increased pressure on the right side of the heart. So if we're looking again at our alveoli, and the ability to supply blood to these alveoli, we know that because of the mucus production and the decrease in lumen size, it will be very challenging to supply oxygen to these alveoli. So we see no O2 making its way into these alveoli, which is going to lead to this buildup of CO2, and it's also going to lead to hypoxic vasoconstriction. So as these alveoli are not receiving any oxygen, we're going to see hypoxic vasoconstriction, or the body's going to attempt to shunt blood away from the alveoli, or the area of the lungs that are affected or not receiving oxygen. So we have hypoxic vasoconstriction. Now the problem in asthmatics is that the entire lung field is affected. So especially in a extreme asthma exacerbation, the entire lung field is affected. So instead of having this hypoxic vasoconstriction at a localized area of the lung tissue, we're seeing it throughout the entirety. So if we draw our heart here, the problem with that is that we know that our blood supply for the lungs is coming off of the right ventricle. So as we have this extensive hypoxic vasoconstriction, our pulmonary artery pressure can increase, or the pressure in the artery that's leading from the right ventricle that's supplying blood to the alveoli is going to increase. So we start to see a fairly drastic increase in pressure. Again, this is in severe asthma attacks. We see this drastic increase in pressure in the right ventricle, and it can lead to basically a right-sided forwards failure of the heart, or the pressure becomes too high, so we see an increase in pulmonary artery pressure. Which leads to an inability of that right ventricle to overcome the afterload. So we see an inability of the right ventricle to overcome the afterload. And this is going to put significant strain on the right ventricle. So one of the problems is we can start to see a decrease in stroke volume, or we can start to see basically a decrease in stroke volume and a decrease in cardiac output from this right ventricle. Another problem is that it's going to increase right ventricular workload. And it's going to increase the demand for oxygen, or it's going to increase the MVO2 while this person is in a state of hypoxia. So it puts that right ventricle at risk of further failure. So we see increased chance of right ventricular failure because now it's demanding more oxygen in an environment that we cannot supply it. So generally what ends up happening here is the person can enter a PEA cardiac arrest. So as we decrease cardiac output, we increase chance of right ventricular failure, and we decrease the amount of blood returning to the left side of the heart. This patient is no longer going to be pushing blood forward. So the electrical conduction system may be working, but the patient may no longer be pushing blood out. So one of the risks associated with severe asthma attack is PEA cardiac arrest. So as the patient becomes severely hypoxic, it increases their chances of right ventricular failure and a PEA cardiac arrest. So the final thing I want to talk about here is the end-tidal CO2 and what we might see on the end-tidal CO2 capnograph for this patient. So you'll often hear what's called a shark fin presentation of the ETCO2 in the asthmatic patient. And what's happening here is basically we have the inability to expire bronchial air. So we're looking at the or alveolar air. So if we're looking at the normal capnograph in phase 2, we have this kind of rapid increase or rapid expiration of our dead space air, which is going to lead to with this rapid spike. So we're seeing that the amount of CO2 we're inhaling is dramatically increasing until we hit plateau, and then we have this plateau where we're going to expire all of the CO2 from the respiratory alveoli and bronchioles. Now the difference in our asthmatic patient is we have this kind of upstroke, or this gradual upstroke of the the phase 2. And what's happening here, why it looks kind of so lazy, is because we're having a hard time getting air out of these bronchioles. So remember, we have the mucus, we have the edema, so we have a drastically decreased space in which we can have air exiting. So it's going to take much longer for this air to expire, or it's going to be harder to expire this air. Now the problem is that you can see this patient's going to reach plateau much later, and as a result they have much less time for exhalation of CO2, or this is kind of indicative of air trapping. We're not seeing all of the air that's in the alveoli being expired at this point. So the person is working hard to attempt to get the air out of their lungs. We see this kind of lazy upstroke as they're forcing or they're fighting that air through those constricted bronchioles. And by the time they hit the plateau phase, or by the time they're starting to expire that CO2 that's built up in the alveoli, it's time for inspiration again. So we see this sharp inspiratory pattern, and then we move through this. So you can get this shark fin pattern on the end-tidal CO2 reading. Again, this is a fairly ominous sign, and the worse the shark fin pattern is, likely the worse the air trapping is and the higher risk this patient is at. So these are kind of the signs and symptoms that we can expect to see in the asthmatic patient. So again, in terms of what can trigger asthma, these patients have exercise intolerance of cold or hot air because their airways are already remodeled. And as we irritate those airways with different temperatures of air or exercise, it can lead to asthma attack. Obviously, we can have asthma attack from our other issues, such as inhaling an allergen. As the person ends up in the acute phase of asthma, or as we enter the early progressing to the late stage of asthma, we start seeing things like wheezing, a prolonged expiratory phase, increased work of breathing, barrel chesting, or hyperinflation. As the person leads into the later stages of asthma, we're at risk of seeing silent chest, an altered LOA. This usually starts with agitation. So the patient will, as they become hypoxic and hypercapnic, they become agitated, and then they start to enter coma. We'll start to see falling oxygen saturation, so our SpO2 is going to decrease. And in the initial stages of asthma attack, we're probably going to have a decrease in end-tidal CO2 as the person is compensating, or they're breathing quickly to exhale that end-tidal CO2 or that CO2. And then as the person fatigues and as their respiratory rate decreases, we're going to see that end-tidal CO2 increasing. Finally, on that capnograph, we often see that shark fin pattern, which is another indication to you that that person's having air trapping and bronchoconstriction. So I hope this helps understanding the signs and symptoms of asthma. Have a great day.